Our next conversation is marking the day today. What day is it today, Jano?
Today is World Cancer Day.
World Cancer Day.
People feel like it's just an October thing. I think that's Cancer Awareness Month.
Yeah.
I like that I'm speaking with conviction and the pro is here.
No, but
But yes,
Yeah,
there's
but
an
no,
it's good
entire
for all
month.
of us to be informed.
Because people usually look at that month as the Cancer Awareness Month,
Yeah.
and November as well as, Men and Cancer Awareness Month. But then there's a day specifically where we mark World Cancer Day. Dr. Timothy Olweny is the chairperson of the National Cancer Institute, and this is a government entity that is at the pinnacle of looking at cancer and cancer cases in this country, all the way from prevention to screening to treatment, and advising the government on what that ought to happen. Dr. Ari, it's good to have you. Karibu.
Thank you. It's my pleasure to be here today.
Yeah, you know the drill. Jano is going to start you off with the day's quote.
Today's quote is by an ancient Chinese philosopher and foundational thinker of Taoism. He was called Lao Tzu. And he once said, governing a great nation is like cooking a small fish. Too much handling will spoil it.
Wow. Like cooking a small fish. I want to assume my ethnic extraction has got nothing to do with the fish question. I'll assume it's purely coincidence.
It's purely coincidence. Yeah, yes.
So I think what it brings to mind is that aspect of too much meddling sometimes in systems, because systems sometimes are invisible yet very pervasive. So sometimes when you meddle too much, you end up not really knowing where you are, and you end up with unintended consequences. In medicine, sometimes we call it masterly inactivity.
You call it
Where
what activity?
Masterly inactivity.
Okay.
Where you have a watchful eye but don't really intervene unless you really have to. So that's what it brings to mind.
Yeah, it's
You're a
exactly.
master in inactivity.
Master inactivity.
Masterly inactivity.
Masterly
Masterly
inactivity.
Masterly inactivity. It's good. There's wisdom to it.
That's a big one. Cancer conversation in this country, Dr. Even the last time you were here, we talked about cancer and the work that you're doing at the National Cancer Institute. But cancer is a big thing in this country in that it is causing very many deaths. It is affecting very many people, both those who are diagnosed with cancer and their immediate support systems and communities, and it is impoverishing very many people. On this World Cancer Day, do you think Kenya, and I'm not saying Kenyans, I'm not saying government, I'm saying, do you think Kenya really understands how serious cancer is?
I think we understand how serious it is, but I think more at personal levels when we're impacted by it directly. But I think it's important for us to have a national conversation about this existential threat we call cancer. And I always like to simplify this discussion by just to explain how serious this is. For example, during COVID, to date, I think we lost about 5,600 lives. Every year on our roads, we lose like 4,500. And we regard it as a very serious disaster.
Yeah.
In Kenya, we lose 27,000 plus lives to cancer every year. We're talking about 80 people dying every single day. And the mere fact that they die separately or in isolation, for example, if you put 80 people together and they all died, what would that be called?
A massacre.
Yes.
It's not,
Right?
it's not just a crisis.
Right? So that's the level of threat that cancer poses. Now, to make matters worse, there are projections that this is going to increase in the next decade. We're going to have a 60% increase in the number of cancer cases. And the majority of these, again, are going to be the low and middle income countries, where we already have 75% of the deaths. In other words, there's what we refer to as a mortality gap. Much as it's increasing globally, we have in low and middle income countries, we've got a disproportionate proportion of the deaths that are occurring. We are diagnosing cancer late. Our treatment is more expensive, yet again, we've got less in terms of resources to be able to manage this disease. So that's the level of burden we're talking about cancer in Kenya and globally.
This 75%, so 75% of cancer deaths globally
Yes.
will occur in these lower income countries.
Yes.
In the poorer countries.
Yes.
Late diagnosis, cost of treatment and all.
Yes.
Is late diagnosis a factor of information or a factor of access to health services?
It's a combination of many things. In general, anything that has got to do with poverty when there's poverty, for whatever reason, it has been proven time and again that there's a multiplicity of deprivations that conspire to make sure that the adverse health outcomes are just much worse. So it's a combination of, first of all, not being able to get the screening. There's an information gap. You can't afford the screening. You can't get the treatment. The treatment you get is inadequate. You're diagnosed late. Outcomes are poorer. So it is just a combination of many things. Yeah.
Let's go through our cancer burden. You've said 27,000 deaths a year, 80 a day. Incredibly worrying. When we start, and we'll come look at like the structures for prevention, early detection a bit later. But what are the most common cancers in Kenya? And also from a geographic perspective. I know we've had the conversation before, but just as a reminder to our viewers and listeners.
The most common cancer in Kenya, we refer to them as the big five. You've got breast and cervical cancer. You've got prostate cancer for men. Then you've got esophageal cancer and colorectal cancer. Those are the big five. In fact, they make up almost 52%.
Say them again slowly. Breast and cervical.
Breast and cervical. Prostate. Then we've got esophageal cancer and colorectal cancer. So those are the big five. In fact, they make up almost 52% of all the cancer cases in Kenya.
52%?
Yes. So in fact, if we could focus our efforts at preventing and effectively managing these cases, it would significantly reduce our cancer burden. You know, one of the things that we have to invest in is prevention and early detection, because we don't really have a choice, especially in a country where we are resource constrained like we are. And that's why I think we need to be able to focus our efforts. So there's a lot of advocacy both within and without government for us to be able to make sure we deploy some resources to that end. Otherwise, if we keep trying to intervene downstream, we will never be able to catch up.
I'm looking at cervical cancer, and at least I can see movement in there, as far as prevention and essentially eradicating it, right?
Yes.
With the vaccination, the HPV women.
Yes.
And there are countries that have done it actually, essentially. There are countries that have eliminated cervical cancer. Does anything exist similarly for the other big four?
Well, there's no in terms of serious interventions.
Yeah.
Yes, you see, for example, for prostate cancer, you can be able to intervene if, for example, you do the screening at an early stage. You can be able to get prostate cancer and get pretty good outcomes as well. Breast cancer, again, breast is very amenable to prevention through regular checkups and so on, mammographies and those kind of interventions. So a lot of them, by and large. Colorectal, a little more tricky. Of course, we still have ways in which we can be able to do stool and check for blood in stool, but ideally endoscopies are a little more difficult to deploy on a large scale. You see, for you to have an intervention that is effective, first of all, it must be fairly cheap. It must not be very high tech in terms of the personnel that are required.
Right.
And then also, again, it must be able to catch the cancer early and catch the cancer at a stage where it's going to make a difference in terms of outcome. So those are the combinations of things when we talk about aspects like prevention. Yes, but by and large, there are very many things to do. But we must remember also that prevention also involves, I don't want people to get the impression and think that cancer it's just bad luck, it catches you. As an individual, you also have a role to play.
In screening.
Yes, in screening.
But
leave alone that, there's what we call modifiable risk factors. Risk factors, things have got to do with diet, things that have got to do with obesity and diet, alcohol consumption, tobacco consumption. Those are all things that are within our individual control. So let's not make it look like we absolve individuals of responsibility when it comes to it. There are certain things.
Just it's a curse. You know, it's funny you said that, because that's what I was going to ask. There's also a lot of superstition and stigma, which I don't know whether that also plays a role in, screening. Because I feel like, and I don't mean to sound simplistic, but I feel like a lot of this can be addressed with early screening. And then I wonder why every year we're here talking about screening, but uptake is low. You've talked about awareness. I wonder if it's awareness. I wonder if it's cost. I wonder if it's superstition that keeps people from screening. So talk to us about why uptake remains low. And then talk a little bit more about, I think the other question I was going to ask was around first let's start with screening. There's something else around what you said about geographical that I wanted to come to. But uptake for screening.
First of all, I think is awareness, and that's one of the things that we keep trying to do, and that's one of the reasons why I come to shows like this when I get an opportunity, because you have got to get the information out there. Knowledge is power, so once we empower people with that kind of knowledge, second is for them to be able to act on it. Unfortunately, sometimes you've got people who might be willing to be able to get the screening, but they don't have the wherewithal in terms of resources or in terms of the facilities available for them to be able to get the screening. So those are things that we have to make more available. But you have to understand from a an individual perspective, you put yourself in the shoes of somebody who is barely making it. Every single day they are barely able to eat and meet their daily needs. And yet you talk about something like cancer, which is an unforeseen event. They're not likely to deploy their resources in terms of screening. And that's why my position is that, by and large, screening has got to be funded by government. If you were to ask me, if we're going to make a difference, it has to be available widely and it has to be free, so that our job is to encourage people, to give them information and make sure they go for the screening. But if it is one of those where people have to pay out of pocket, the uptake is going to be very low. Leave alone the aspects like stigma and so on. The first step is, most of the time, it just doesn't come to mind. I can't afford it. Yep. I'm barely able to meet my daily needs. I'm worrying about the normal things in daily life.
Right.
Yes.
Or even if there's a persistent pain or something of it.
I don't want to go to hospital because it costs me a lot. I'm trying to jump in here with a question before it moves away, because we have a law called the Primary Healthcare Act, right? And this says primary healthcare will be taxpayer funded.
Yes.
So that at level 1, who is the CHP, to a level 2 and level 3, you are able to go to a health facility and get back home. Does screening not happen in these levels?
It happens to some extent. If you ask me, there's a lot of room for improvement. And I'll say this because, first, there has to be a change in mindset. And the mindset of the healthcare provider has got to be that screening is not a staccato type event which you do when there's World Cancer Day and so on. It has to be integrated into the primary care of every single individual. So I'll use the term profiling in a good sense. When an adult male of a certain age walks in, I have to profile them and say what cancer they are at risk for, and ask targeted questions about whether they've had screening for this type of cancer, and try and make sure it happens. So it has to be integrated into regular care, as opposed to these sporadic events, for it to be effective. Then that way also the mindset changes amongst Wananchi. It becomes normalized, because now as you go and discuss in the community and say, oh, by the way, I went and had my prostate screening, I'm asking somebody else, have you had yours? And so then they asked, how do you get this done? You say, just go to the facility and this and this. So those kind of things, even it demystifies the aspect of screening. It'll help lower the aspect of stigma. We'll be able to catch cancer earlier, and therefore now cancer will not be a death diagnosis, so to speak. The stigma will reduce, so the effects are going to be multiple in that sense. But it is important for us to integrate that into regular care.
Integrating it in that regular care is a job of the healthcare workers.
Yes.
And the system.
Yes.
The health system.
Yes.
Right? Starting from a policy level at the ministry.
Yes.
And the Director General of Health just issuing that guideline for all health workers in this facility. This is how you do it, right?
Yes.
With advice from the National Cancer Institute.
Yes.
Have you given that advice?
Yes, that advice has been given, and it even goes before that. We don't even get to the point where we are going to training institutions. This is integrated into the curriculum as you train healthcare providers. So that is how it should be done. You start from the word go. So even as a med student or a clinical officer or nurse, as they graduate, as they finish, it is already part of the process. But you see also they learn from the institutions where they train. So for example, if the health facilities they're training in are doing this, then it becomes part and parcel of their day-to-day activities, and therefore we can integrate it into care going forward. But it must be funded, because at the end of the day, it has to be that there's a way in which that cost is going to be taken care of. It is not a monumental cost, but if you look at the potential costs we're looking at downstream for failing to do this, it makes a lot of sense for us to invest in all these interventions upstream.
I'm not getting the cost aspect yet, because the National Cancer Institute will come up with the material using all the experts on cancer that you have in Kenya.
Yes, correct.
And the medical training institutes that you have in Kenya. There are not many.
Yes.
And they are clearly licensed, and you know which ones they are. Now, if you come up with a curriculum, that's a one-off curriculum that's then being deployed in these institutions. Cost element, okay.
Now I'm talking about the cost of the screening itself at the point of care.
I'm coming down.
Yes, okay.
The advice that you give to the Ministry of Health, and the Director General of Health then deploys this to the health facilities through KMPDC that licenses the facilities, and KMPDC that licenses the healthcare workers, and even the others, the clinical officers, registrar, and the others, is again uniform. It's information.
Correct.
So we start from information.
Yes.
Has that information been unified the way we've just described?
Yes, it has.
Like there's a curriculum
in
all training institutions
Yes.
that has been passed and approved, that there's a policy and a guideline from the Ministry of Health on all healthcare workers. Is that there?
Those are in place.
Okay. Now, what is missing is the capacity to actually do the screening.
Yeah, not in terms of human resource capacity, but I'll talk about the resources in terms of financial resources.
Okay. So what is that? Have you costed it?
For each of those tests, that was supposed to be part of the primary care package, right? Unfortunately, because of resource constraints, that was not given immediate priority. However, in the last year or so, again, there have been initiatives now to be able to beef up the kind of resources that we're going to deploy towards screening. In fact, there's an initiative in terms of they're supposed to separate fund to be able to fund prevention and screening, and that's going to be important because it's going to make the huge difference. Yeah.
What does that mean? Are we talking about equipment?
Not equipment.
And labs.
You see, the equipment and everything else is in place. But you see, I keep saying what you incentivize happens. In the absence of us saying that through this scheme, or whether it is a private insurer, whether it is SHA, or whatever, there is somebody who's going to pay for that when Janet comes and decides to go for screening. If she has to pay out of pocket, chances are it's going to be a lost opportunity.
Again, this is where my issue comes in, right? Because if all these things are in place, if the equipment is in place, it's the issue of who pays for it. We have a law in place that says who pays for it. The law says the taxpayer. It is coming from the exchequer. So even who is financing this is clear in law. So where is the gap here then, Daktari?
And I'm also trying to think critically, like if you go to a CH, as you answer that, a community health promoter, like some of the things he's talked about as far as, early screening detection, even profiling, is a CHP typically asking, oh, do you have a history of this and this in your family? Or, oh, how old are you? Have you had a pap smear? Have you had a mammogram? Have you, no. I don't know if those questions are also being asked in a typical, or is it, let's check your blood sugar, your blood pressure, and
that's
then
it.
Go home. I don't know.
Yes.
And then
the CHPs, of course, in terms of their technical capacity, it is being enhanced and it is training that is part of the process. They are a very powerful tool because they form a huge army of people who actually go to the grassroots and are able to go to the household level. And the good thing is, for example, that you don't have to be a medically trained, for example, to be able to say, you're told if there's an adult, you can ask them, an adult male, ask them, have you had prostate screening? For a girl who is, if they find a girl who is 10 to 14 years old, have they got an HPV vaccination? So that's the kind of information that we are. So it is going to take a little bit of time for us to see the effects of that, but at least the process has started.
And then now his question, where is the gap? If essentially it's community health promoters and everyone in the chain of healthcare provision has this information, some of the equipment exists, shida iko wapi?
It takes a bit of time, first of all, for wananchi to come around and first of all, for this to take root, firstly. But secondly, again, I talked about resource constraints. And those resource constraints are being worked on. I'll use the term that people at Treasury like using about the fiscal space. But of course, like I said, the intention is good. The intention is good, we just need to give it more. And that's why there's a lot of advocacy. Even for us within government, we lobby every other single day. And that's why, for example, you'll find even the amount of money disbursed that was made available for cancer patients increased in the recent past. It might not still be sufficient for some cases, it is sufficient for some, but there's initiatives that we have to make in terms of making sure that every single patient who gets cancer can be able to go through the treatments with financial risk protection, as in they don't suffer financial hardship. Right. So it's a journey, but the journey has started.
I'm being pedantic on this, because it appears that everything is in place, but nothing is in place. It appears like everything is in place, but nothing is in place. So all this, what we are saying is, today we should be able to tell people that you can go to a health facility and the clinical officer that you find at the health center or dispensary should ask you these questions and should facilitate you to get screening, right? Now, that should not cost you because this is at primary healthcare level, which is taxpayer funded, all right? Now, are you saying that the budget allocated for primary healthcare in the current financial year is not sufficient to cover for that cost? And if so, how much more should we send to primary healthcare?
You know that question.
Like I'll ask you the question that the education CS was asked. How much budgetary allocation should we have for screening at primary healthcare level?
You know, unfortunately, I don't think that is within necessarily my mandate in terms of being deciding the budgetary allocation.
No, it is. It is, Dr. Ali. I'm sorry. It is. As the chairman of the National Cancer Institute, you're the one who advises.
Yes.
Right? So you've come up and said, this is what we need. We need to train medics. Then this is what we need. We need to have equipment at the health facilities. Then this is what it's going to cost to run this equipment at the health facilities. So how much is it going to cost to run equipment at the health facilities? So then we can go and tell Badi, no, we can go and tell our MPs in Parliament, make sure that this amount is there.
I'm reluctant to jump the gun on this one. I understand where you're coming from, Eric, but allow me to defer that question, because that question is between the certain different organs of the ministry. So it's a question that has to be answered by many people combined. One thing I can assure you is that resources have been deployed. They're not sufficient. There's an additional budget which is planned, and I don't want to talk about it in advance of that date, but there are plans being made to be able to increase the resources we have deployed towards especially prevention for cancer.
Let me flip it around. Was the National Cancer Institute consulted when oncology packages for SHA were being created?
Yes, they were consulted.
Then how do we end up with multiple cases of people saying this was not able to cover my treatment? And we'd even spoken earlier, about different cancers and how they present and how much they cost. But again, if the National Cancer Institute was consulted, then you would have said, not all cancers are the same. Some cost $1 million,
Yes.
Bob, others 300,000.
Yes, we started. Let me tell you, when you're designing benefit packages, you have got so many diseases that you have got to deal with. So at the moment, the tendency was initially for the cancer packages, what was adopted was the model that was there with the previous NHIF. However, at the moment, and there are initiatives, and personally, I believe strongly that cancer needs to be broken down into many different types of cancer, and we have benefit packages that are individual. So that is work that is in progress, and especially for the big 5 cancers, because I've told you the big 5 cancers are the ones that cause the majority of the cancer cases, so that we get to a point where everybody gets cancer benefit, a cancer benefit that is commensurate with what type of cancer they have. Because at the moment what happens is you have got an allocation which sometimes is in excess for certain type of cancer and falls way short for others. Yes.
And you see, but there's again complaints of people saying under NHIF, my treatment was covered. Now I have to go out of pocket. So if it was the old model,
Did NHIF really cover cancer treatment fully?
No, it didn't. It still didn't cover it fully.
But we've profiled the story.
Anecdotally, they've said they had less of a burden.
Yeah, they had less of a burden on NHIF than under SHA. So if it was the same model, then what changed?
Yeah. Can we come back and
Okay,
answer
so,
that
yeah, let's
and
take a
continue to interrogate more of the structural issues
Yes.
today, and also awareness? There's schools like in the UK, Australia, where it's integrated into the school curriculum. I don't know whether that's what you spoke about. No, school curriculum. So talking to young people and many other issues. We're talking to Dr. Timothy Olweny, the chairman of the National Cancer Institute. Lest we forget, we have a cancer burden in this country. What do we need to do to move the needle? It's coming up to 9 a.m. We'll come back and continue the conversation with him.
So Dr. Timothy Olweny, the chairperson of the National Cancer Institute, is still here with us, reminding us that today is World Cancer Day, and we must elevate the conversation around cancer and understand the burden that cancer is to Kenya, psychologically, financially, and even burdening our health system in terms of it's a huge cost to bear. But it also could be lessened a lot if we started from the very beginning. Awareness and screening. That's what you say. And that's what the National Cancer Institute is championing a lot of.
Yes.
Awareness and screening.
Yes.
Now, you said these are many things that we can avoid if you just think about your own lifestyle, what you eat, what you drink, what you consume, how you live your life, how much you exercise, and so on and so forth. That's important information. I'll tell you, Daktari, that we have had these things from doctors many times. Why do you think we don't get it? Let's start from that point, because clearly there's a disconnect somewhere. Either we get it and we do it half-heartedly, or we just don't get it at all. But we've heard.
There's one thing that is, there's knowledge, attitudes, and practices. And the knowledge can be dispensed with, but it takes a while for these other ones to take root. Sometimes it might take personal experience, or, other than anecdotal reports you hear of what first-time interaction, and somebody tells you this is what exposed them to risk. Because, for example, you'd say, smoking, for example, is one of the things that has been known. I've never known anything positive that can come out of smoking, all right? but people still smoke, all right? So some of those things, it takes a while for them to take root, but the key thing is that we cannot tire in terms of giving advice and making that causal connection between, because 40% of cancers are actually related to these so-called modifiable risk factors. So it is important, because these are studies that have consistently shown that you do certain things, you put yourself at higher risk. And worse still, especially, I think, if you are somebody who's already predisposed because of hereditary predisposition, for example, at another 5 to 10%, then you cannot be engaging in those activities.
I want to ask something. I know we were talking about structures before, and we'll come back to that. Just based on the awareness question Latif has asked, because I was doing some quick reading. In Japan, schools include cancer education modules focusing on prevention, early detection, and lifestyle risks. Same thing for Canada. They integrate cancer prevention topics into health and physical education. In the United Kingdom, secondary school health education covers cancer risk factors, HPV vaccine awareness, smoking, alcohol use, and healthy lifestyle choices. And finally, the same thing in Australia. Cancer prevention, including sun safety, smoking risks, vaccination, etc., is part of national school health programs. So there's something there, because now you're telling adults don't smoke. I'm like, I wonder what argument can be made to follow what some of these countries are doing, because then you're telling kids early, then they know. Okay, I'm sure they're told all the time. But then if you're told the spectrum of the risk, alcohol use, smoking, etc., maybe then it's a lot easier to speak to an adult population that has already learnt it early.
It is true.
Is that something that's been considered or
It's
even
been
done?
considered, and the earlier you start, if you ask me, the better. And I'll give an example, even though context is important, because our circumstances in different countries vary a lot. I'll give an example. Most people who grew up in African homes, especially those who are a little older, like myself, basically people grew up poor. You cannot start giving advice. At that point, the advice, for example, about these excesses of diet and so on, did not really apply. In fact, I remember I've got is an uncle of my wife's uncle who told me once that, believe it or not, until the time when he started working, he could not remember a time when he was actually full, as in he's eaten and he's satisfied.
Umeshiba.
All right? Now, you can understand how,
Yeah,
and unfortunately, some of those so-called, I'll call them cravings, shape what our future habits in terms of eating are. Unfortunately, everybody goes to school and says, well, I'm eating this gideri like I did in school endlessly, and so on. One day I'll be able to afford good food. Unfortunately, that good food usually, again, is food that is not necessarily very healthy or good for you. But at the time when you start working, that's why now you start gaining weight, because you're eating all these things which you've craved all the time. Then now, again, you're less active. You're living a more sedentary lifestyle. And then you see how you run into all these things about obesity and physical inactivity. Most of the time, people were walking on foot. It was more healthy, but we deemed it as suffering, isn't it? At this stage now, if, for example, even I was to go to work and told guys I'm going to ride a bike to work, most of the people at work will say, Daktari, it's not looking good for us if you come
It's
on a
good
bicycle.
for you to point out that context.
Is everything okay
Is
at home?
everything
Yes.
okay?
Kwani, are
but
things going under here?
That's very important context.
Yes.
So I'm just wondering where the middle ground
So
is.
it has to be, I'm saying all this education has got to be contextualized so that you can be able to understand. I'll give you a funny example. One day in the village drunkard confronted me as a doctor. And I was sitting I just walked and they said, you doctors are very bad people. I'm looking at him like, what have we done now? And his point was, he said this, doctors want us to suffer all the time. When us guys are poor, we can't afford anything. You tell you go and eat liver, eat eggs, have to be a little bit of fat in your food and so on, things we can't afford. Once we are now able to afford it, you go back, limit the red meat, limit eggs. And so they said, it's just a scheme. You guys what do you guys want? But you understand where people are coming. So all I'd say is a lot of these things in moderation. The fortunate thing is, by and large for us, a lot of the time, especially because we are low to middle income country, a lot of these excesses sometimes don't, the majority of the population. In fact, you'll find a certain segment, the middle class, and going forward, possibly the ones who've got this problem, the sedentary lifestyle, and so on and so forth. But those things are changing. In the US, if you talk about context, you'll find the people, again, who are living in so-called poverty are the ones who got a problem with obesity. Because now, again, they've got these unhealthy foods, or cheaper ones, and so on. So things are very different. When we talk about recommending plant-based diets, for example, majority of our population is already on a plant-based diet.
Yeah.
You understand? So there's no
Organic
need to
eating, it's already organic.
But there's a certain segment again where you need to emphasize that message. So to have two-thirds of your food a plant-based diet, limit the animal-based food, for example. Not the same as going vegan, for example, because again there's use for some of these other foods. But that's what I'm saying. Advice has got to be contextualized. But in terms of training schools, I agree with you. We need to start the message earlier because it becomes part and parcel of. And that's why I keep saying, even when we go even for sometimes meetings out of the country and so on, I look at the plates of people from our African countries and some of the plates of the. It's kind of different. It's kind of different. I was in fact one thing I've never understood is why the watermelon has to be on top of the pile.
At least we're eating fruit.
We're integrating.
It shows we're eating fruit.
Yes.
On top of all the nyama.
Also, there's no separate plate for the fruit. It's just, and you want to eat this, so you just put the watermelon on top.
Why the watermelon? Why don't you need the fruit? Or it shows a sign, I'm done.
I don't know. It's just
abundance.
that it's the standard. It's a standard catering fruit. Let's be honest.
Why?
A caterer, you ask them provide two starches, two proteins, two veg, and a fruit.
It's
It's watermelon.
watermelon.
It's
I
cheap.
think it's cost effective.
Yeah.
That's it.
We'll come back again
And
to
one
some
can
questions.
serve many.
Yeah, just another funny one. But yeah, he's right, because there's a conference we went to in Germany, and the year before, it was very like healthy and balanced. And there's a lot of Kenyans who are complaining. The following year, the excess of meat. And the caterer from Germany said they really complained. They said they can't come all this way and just eat grass. So Nisisi, by the way.
Kenyans have also made fun of me. I posted, like, I was abroad and then I posted a school meal and it looked like githeri, something similar. Mara umetoka Kenya kukula githeri.
Wow. On a flight and all. Again, back to the systems, but before that, Lenny D. Steve says, is the HPV vaccine feasible for boys? Break that down, because some people may assume, no, it's for girls and women. Is it feasible for boys?
I think the key thing here is to be able to limit the infections. And of course, infections are transmitted most of the time sexually. That's why we try and catch people before they're sexually active. So I can see the rationale for that. I don't know whether there's any intent at the moment to be, because at the moment the focus has been on girls, because primarily, again, they're the ones who end up getting cervical cancer at a later stage and getting infected. But I can see the rationale for that. I know there might be other jurisdictions that are already doing it. In Kenya, not yet. Yes.
Okay. Getting back into what I had asked, as far as the structures that we're building for early detection, for prevention, and you've given us an outlook of what it should look like ideally, but then there's the gaps that exist currently. Let me take it now to us, from a personal perspective, what can we do as far as early detection is concerned, and especially when resources are limited, because again, medical care is sometimes a luxury, right? So if the CHP is not knocking on my door, what is the likelihood that I'll take myself there? What can I be doing?
I think it's just in terms of, first of all, information usually comes for free. Unfortunately, again, it's not very available. So what we have to emphasize is try and make this information as widely available as possible. Secondly, it's about vigilance at an individual level and at a bigger level for institutions like ours at a national level. But vigilance in terms of being able to monitor trends, being able to catch people early, and any opportunities that we get for being able to get people to be able to have screening, take those opportunities. So I think that's by and large, that's what we can say. But the information and also people have got to know what their individual risk profiles are. So by and large, because first of all, you're of a certain gender automatically, you come from a certain family, you have got certain risk factors, and then again, as you transition age-wise, the risks change.
Keep changing.
Yes.
I'll talk about risk profiles in just a minute, but we've got a caller on the line called Kip Kemboi. Good morning, Kip Kemboi.
Yeah. Hello, ma'am.
What's your question for Dr. Timothy?
Okay, one is that I've been watching all through from the time he came in, him articulating the issues about cancer and the science. So mine is, what is this thing about, let him tell us, what is this early detection and late detection? What is it all about that? Maybe if it is detected late, it may not be treated. But then two, let him also articulate, knowing that there are a lot of people who stay up country like us, who may not have that funding or maybe the ability to be able to go for screening. Can he be able to articulate what are these early signs that somebody has maybe that infection of cancer? so that we may be able to get to know, because there are a lot more people who are walking around, maybe infected, but they are not aware. So the only thing they can use is the signs that crop up for them to be able to know that, it is time now to go for early treatment.
All right, thanks, Kipkemboi. Let's hear from Dr. Ari.
Okay, so those are very good questions from Mr. Kipkemboi. Early detection, let me go back a little bit and explain what cancer is in the first place. Cancer is that you've got some abnormal cells in your body that are multiplying without control. In general, what happens is they multiply, they go beyond the normal boundaries, so they invade other tissues and organs, and then potentially also they can spread to different distant parts of your body through the bloodstream or what we call the lymphatic system. So that's what cancer is. So in terms of looking at when we say early detection, we want to catch it at a stage where cure is possible. So you want to catch it before it has spread regionally, or spread to distant parts of your body. And also that gives us the treatment options available. If it is local and it has not spread anywhere else, potentially surgery or removal of that piece of tissue or part of the body where the initial what we call the primary tumor is, will be a cure. If, for example, you go to a later stage when it has spread to a regional tissue, now the treatment options become more, for example, now we're talking again, as opposed to surgery, we're talking about forcible radiation therapy, because now it has moved somewhere else. Now, when it gets to a point where now it has spread to distant parts of your body, now you have to give what is called systemic therapy. All these things become more expensive, and the more systemic your therapy, the more potential side effects, the more likelihood that it is hammering your normal cells as we treat, as opposed to just the cancer cells. So it has got a bearing on the cost of treatment, on the treatment options that are available, and the chances of cure. So that is why we keep emphasizing the aspect about early detection, because if you detect it early, the outcomes are much better, and resources which you're going to spend are much less. So at an individual level, it is both cheaper, you're more likely to survive longer, and the outcomes are better. At a national level, if you look at the national level again, the amount of expense that we're going to deploy and the resources to treat this illness are going to be more. I hope now I've broken it down a little bit better.
Yes. Yeah. Then
he talks about early signs. Early signs of cancer will depend on what type of cancer. Because cancer, you can have cancer of literally any tissue that you have in your body, except tissues that are dead cells. That's what like people forget. Like hair and your nails, and for example, what we call the enamel, and those are dead tissues. They can be affected by, but they do not get cancer. The more rapidly your cells divide, the more likelihood you have in terms of getting cancer. And that's why any part of your body, for example, that is exposed to the outside, you've got the linings of your mouth, the gastrointestinal system, and upper respiratory tract, and so on. That's where you tend to get, because again, you've got cells that are being, because of wear and tear, they are being replaced very rapidly, so they are multiplying. Same with your reproductive organs, for example. So that's why you find even our big five, you'll find they're going to be in organs that are gastrointestinal, you're going to have breast and cervix, you're going to have colorectal, and so on. So early signs are going to be determined on where it starts. So for example, it might be that in your breast, it's going to be a lump, right? For example, those are early signs. So it all depends. Unfortunately, there are some which are kind of hidden. So those are the ones, unfortunately, that tend to be diagnosed late. For example, you've got colorectal cancer. It is inside your tummy, so to speak. By the time you detect it, possibly is when you start doing blood and stool or something unusual. So that's why we talk about these aspects of screening. We are trying to make sure we catch them before they get too far. But in terms of early signs, in general, there are some that are common for all cancers. Things like weight loss. Sometimes you've got somebody losing weight, they've got sweats, they've got fever, and so on and so forth. So any unusual change, I think, should point someone towards saying, you know what, something might not be right, let us go and see a doctor. But then there are those that are specific. If you are fortunate in certain senses, there are some that present with pain fairly early. Sometimes it's a good sign, because again, it means you go and rush to see the doctor. You know, pain is the number one thing that makes people go seek medical attention. And then there are some where something could be growing for a long time and causes no pain and don't even no symptoms. By the time they catch it, you're told it has spread to other parts of your body. So it is about people knowing their bodies and being vigilant, and if there's any change that you find unusual and so on, go and seek medical attention.
Okay. How regularly should one screen? Because now you're assuming that you have a full healthy body.
Yes.
You don't know that maybe you're at a certain early stage of cancer.
Yes.
So you don't even know which part you're going to screen.
Yes.
You can't say, I'm just going for breast screening. It could be on other parts of your body.
Yes.
So how often should one go for a full body screen?
I don't know whether we'll talk about full body screen, so to speak, because again, you cannot say that you're checking for all possible types of cancer. And that's why I said the key thing is, we'd say in general it should be annual, but by and large, I want the healthcare provider to take the lead. As long as you go and seek medical attention for whatever reason, the healthcare provider is the one based on your presenting symptoms, for example, or based on your profile in terms of age, in terms of your pre-existing illnesses and so on. They will tell you, I think it's a good idea, Eric, let's just check for this and this.
Right.
Okay.
We've got Peter on the line from Nairobi. Peter Kimathi from Nairobi, who wants to changia kidogo. Good morning, Peter.
Good morning, Sue.
Do you have a question or a comment for Daktari?
I have both a comment and a question. One thing, I must commend our public health facilities for the good work they are doing towards cancer of the cervix and breast screening. I think most of the public facilities I've visited, they do quite a lot towards early detection of cancer of the cervix and cancer of the breast, including patient education. Now, amongst the big five that Dr. mentioned, there is throat cancer and colorectal cancer, which from the people I have seen, heard, attended their rambles, it's like a death sentence. Truth be told, I've never seen anyone survive throat cancer. So I wanted the Daktari to maybe clarify what is the Institute doing towards, one, more research on those two cancers and other cancers that we as a country seem almost clueless on how to manage, because the burden is huge. Like, these two cancers will leave the family depleted of all the finances, and the patient will end up dying. Number two, we have seen previously, even NTV has run a documentary on pesticides. And I think those are things that are easy to achieve. Having legislation to protect people from these harmful pesticides that have been strongly associated with cancer. You have some pesticides that have been banned in the US for even the last 15 to 20 years, but they are still in use. And now it begs the question, why do we have a Cancer Institute, why do we have CARES, why do we have all these bodies which can push legislation to protect people? Because such, like these cancers, colorectal and the throat, they have been strongly associated with these harmful chemicals. So I think the President Daktari to maybe shed more light on what the measures they are putting towards protecting Kenyans.
Thanks,
and
Peter.
Number three, still the financial burden is huge. And SHA, I can't say it's really working for cancer. So thank you.
Are you a healthcare worker, Peter?
Yes, I'm a healthcare worker.
All right. Sawa. So this is
Peter,
something you...
let me ask you that question, because Daktari, and you heard the Daktari say. So, as a healthcare worker, and are you trained and sensitized to take the lead in asking your patients those leading questions about screening?
Yes.
So how do you do it?
Trained, but like for cancer of the cervix, it's something that we routinely do for every woman of there is a criteria. Every woman visiting the facility has to receive education on cancer of the cervix and establish whether they have had a screening. And the basic ones we do is via Vili and there is a pap smear. And cancer of the breast, self-breast examination and clinical breast examination. But something like cancer of the throat, most of the facilities, unless the patient is symptomatic, the patient has shown symptoms, it will be very difficult to have a primary screening tool to diagnose, to suspect that the patient could be having it. Colorectal cancer, same, unless mostly we bank on previous experiences. If there's an immediate family member, a blood relative who has had colorectal cancer, then screening should be early. Yes. For prostate, there is a guideline. At least all men above 40, we're able to screen. But however, I believe even interventions for especially throat cancer, they are very lacking. And I think the risk factors are also not properly addressed.
Okay. Thank you, Peter. So, Dr. I think he says that from his own experience, these two, throat cancer and the colorectal cancer, by the time somebody is coming, it's already at an advanced stage. So what can we do prior to that?
Yes, first, let me just comment on the aspect. I'm glad that he has validated my claim that we have got trained healthcare providers on the ground who are trained and they've got the capacity to be able to do screening. That is very impressive and reassuring. Now, like I said earlier, there are certain types of cancer that are easier to catch because of the manner in which they present. You must see, for example, you can see how far back your throat is. So a lot of the time, unfortunately, and there's also pretty much enough room back there for something to grow without being detected. So throat, esophageal cancer, sometimes you catch it late because it's a tube, there's space. By the time you get to a point where esophageal cancer, someone can't swallow, the tumor already is pretty big. So those are dangers, and I understand his frustration. Throat is not necessarily one of our top 5 that I mentioned, yes, but again, in certain regions, you will find that throat cancer has got a higher incidence than it hasn't. So it's not that the distribution, again, is uniform. So it's a tough one, and that's why I keep saying it's going to be a slight change. At some point, somebody saying something feels different, something has changed, and sometimes an incidental finding. But that's why, again, healthcare workers are going to help us in conjunction with the patients also. You know, patients also have to come and actually tell you what they're really feeling. Yeah. Right. They have to be open enough to be able to communicate that information. Yeah. Yes. Now, he talked about the issue of pesticides and so on, and those are very well-known carcinogens. Now, there's this again is one of those areas where it's a lot of intersectoral collaboration, even within government, because, you know, it goes into the Ministry of Agriculture. You might find other ministries, it goes to the Ministry of Health and so on.
The Kenya Bureau of Standards.
Yes. Like so there's a lot of, but I do know one thing is there's legislation in place. A lot of the time, the biggest challenge we have in our country is enforcement, right? Like in many areas, it might be in terms of enforcement and people obeying the law. The mere fact that you have a law doesn't mean people are going to follow it. Otherwise, nobody would be murdering anybody, isn't it? So, unfortunately, those are some of the things. There are challenges, but we are aware of them, and there's efforts in terms of being able to control, especially these carcinogens in our population. So that's environmental control.
I think the third issue that he raised was the cost and coverage, and you had also raised that earlier, Mariam. So we have the Primary Healthcare Fund, we have the Social Health Insurance Fund, and then we've got the it's called what? ECCIF. Emergency Chronic and Critical Illness Fund, right? Which again, taxpayer funded, which is where now it comes into these critical illnesses, the chronic illnesses that we have. Cancer falls in this fund, right?
Yes.
From the National Cancer Institute's position, how much have you insisted on this being properly funded? Because you see, you are the experts who are in government, who are looking at cancer on a daily basis, and that's your job, that's the job you are given. And you come and advise other government agencies, this is the issue. You started by saying it is such a big problem, especially this big 5, that they are causing many more deaths than you said. Road accidents, even COVID did not hit here, and others. So how much more noise have you made to the Ministry of Health and the Social Health Authority for them to look at the coverage, wider coverage, or even what you proposed, the breaking down of cost per cancer, not blanketing all cancers?
Yes. The noise has been made. In fact, a lot of the time, there's a lady who's part of the Kenya Network of Cancer Organizations, and they are the ones who actually present people who are impacted directly by cancer. And we have the term in the board, we call it kelele takatifu, because it's a joyful noise. And it's their role to be able to advocate. So this noise comes from many different sources. Ours is just one of them. But one thing that I know is there have been enhancements, even before, and from the time the SHARP package was launched to now. And the advocacy and lobbying continues. One of the things I've told you is in terms of stratifying, you might find that we've got a lot of resources which are being deployed, but they're not being properly deployed because they're not tailored to the individual cancer cases we have. That in itself might even increase the coverage without necessarily increasing the total usage of these cancer funds. However, the 800,000 that is being paid at the moment, in a lot of circumstances, is still not sufficient, right? And the good thing, which I can say is, the good thing is government is listening. Of course, cancer is a big problem, but we also have to be honest, it's not the only problem, right? So there are a lot of competing interests in terms of the resources that we have, so we'll do the best that we can. But more importantly, if you were to ask me at this point, is to make sure that the resources that we have at the moment, we use them to the best, to get best bang for our buck.
I was going to ask about survivorship care. Do you want to come in? I feel like that's also ignored around treatment and what that looks like, because you've survived the cancer, but now you're a survivor. I wonder how much of that is taken into consideration when it comes to the cancer burden, but now for survivors, because a lot of the time it's long term.
Yes. Yeah, survivors, again, once you have had cancer, regardless of whether you are declared cancer-free after that, or whether you still have that niggling feeling that you have to keep. And the truth is you have to be vigilant still, because there are times when you get relapses. Now, there are a lot of social structures that are in place, which, for example, I said through these organizations and so on, that provide a lot of support and so on. But one thing that is also neglected, which I like to add here, is the aspect of palliative care. And palliative care, because there are many circumstances where cure is no longer possible.
Right.
And if cure is no longer possible, that is not tantamount to saying that you are abandoned, that there's nothing that can be done. So it is very important that we take care of patients, but especially with my interest in palliative care, I know that it is best that patients be taken care of in their homes, in an environment that is familiar. But now the challenge becomes, at the moment, and this is one of the things that I've advocated again when it comes to the benefits package that we're talking about now, I strongly feel if we're going to fund palliative care only in hospitals, the tendency will be for people to take patients to hospitals. That's not smart use of resources. We need to be able to utilize our resources in such a way, whether it is through CHPs. We've got a lot of hospices in this country that provide home-based type care. Let us support people in the homes. There'll be an environment which is familiar, because a lot of the time, by the way, what frustrates people is when you feel you don't have the support. You've got a patient who potentially is terminally ill, and you're even scared. At a time, you don't know if something happens, what am I going to do? How will I get them to hospital in time? You just need somebody that you can be able to call, who can reassure you, who can be able to come and visit you when required, and if necessary to take the patient to hospital, they'll provide that support for them to go to hospital. So that's one way we need to deploy our resources. I know the infrastructure around that area is not as organized, and that made it difficult to be able to provide the funding. But on the long term, that's one thing we need to do, because we've got a large number of people who are out there in palliative care, in needing palliative care, who are not getting the kind of care that they require.
Let's talk about emerging technologies and how they're affecting cancer diagnosis and treatment so far. Anything new that you would say is changing how we view cancer, either diagnosis or treatment? Well,
technology is one of the, especially in this medical space and especially in this field of cancer, is rapidly evolving. The tendency now is to be able to have treatments that are more focused, because one of the biggest problems we have with any treatments that are targeting cancer cells is that cancer cells, first and foremost, are your own cells. So any treatment that targets them will target your own cells. So now we want things that are more specialized in targeting cancer cells as opposed to, so you got about targeted therapies, immunotherapies, as opposed to what we used to talk about, chemotherapy alone in the past. So those are the areas that we're moving into. Of course, there are new molecules being introduced every day. The thing about them is a lot of the time they're extremely expensive. And so you have to, again, from a public perspective, be able to be clear that if you're going to deploy resources, you're going to get outcomes that justify the opportunity cost in terms of how many the patients you'd be able to take care of, as opposed to this. From
a research perspective, I don't know if you know what's happening, because, we shouldn't be the ones funding the research, essentially. You know, it should be government through KEMRI, etc., so that we get to a place where we're able to find these therapies and, of course, test them, and then have them be adopted large scale. It takes time, it takes funding, it takes concerted effort. Is that happening anywhere here?
It is happening. Even within the National Cancer Institute alone, we fund research, both intramural and extramural research. You've got, for example, KEMRI, you've got a lot of teaching institutions. So even if you look at the constitution of our board, these are the people who sit in our board, actually. You've got people from research institutions, you've got people from teaching institutions, universities, and so on. Then you've got other professionals and so on. So that's the constitution. So we are putting our minds together, and one of the things that we also, our approach at the National Cancer Institute is, if you are to wait to be able to get exchequer disbursements to the extent that you'll be able to, you will never do anything. We have got to be innovative. You have got to use some ingenuity in terms of being able to mobilize other resources, partner with other people so that you make sure you still achieve your objective. And that's why we've got a lot of partners who come in and help in terms of the research, in terms of our activities, even in terms of the screening right now and so on. Those are the things that we are involved in at NCI.
The joy of having the Cancer Institute is that you sit, like I kept saying, you're at the apex of the cancer conversation in the country. From research all the way to treatment to awareness creation and prevention, right? Now, I don't know to what extent you're able to get all the research information and harmonize it. So we have all these different institutions that are conducting research on different things. Some funded with the support of yourselves and others not. Kenyatta University Teaching and Referral Hospital has been doing some extensive work on cancer.
Yes.
Aga Khan University, the same. The medical degrees, the same. Now, do they bring that information to you at the end so that then you have you're the repository of cancer research information in Kenya that helps you then to advise the government on the way forward?
That is the ideal situation, and that is work in progress. One of the biggest problems we have within this cancer care ecosystem is that we've got very many players, and everybody means well. And sometimes they are so focused in terms of doing what they do that they don't look up and share this information to other people. So one of the biggest roles that we have is in terms of, other than providing leadership, it's about coordination of these efforts. And second, making sure these efforts are sustainable. Because that coordination aspect, even when it comes to for example, you'll talk about something as simple as the screening efforts and so on, you'll find every single day everybody is doing something somewhere. So this coordination role is one of the biggest things, and it's a huge challenge because, like I've said, and you've also admitted, even in the area of research, we've got so many people who are doing research, but it's important that we get this information to that. So in fact, one of the themes that we had in terms of this World Cancer Day is that one of the things is that we want to move from fragmentation to integration, because we've got a lot of fragmented things all over the place, and sometimes, guess what, even in the presence of that fragmentation, there are still going to be gaps.
Yeah.
There might be some people, and you see a lot of, especially if things are driven by funding. Funding sometimes is not going to cover certain areas which are not viewed as part of their objectives and so on. So those are the thgs that we have got to make sure to do. So there's a lot of work to be done still.
What will it take to actually move from fragmentation to integration?
It is, especially first of all, in terms of this knowledge sharing, is a lot of technology, right? In terms of sharing. That's one of the, for example, things like the cancer registry which we have. At the moment, the biggest problem we had is the cancer registry. Sharing information on that platform is more or less almost voluntary. So it is incomplete. So one of the efforts that we are making sure right now, trying to make sure, is that increase the quality of the information that we get in terms of how comprehensive it is and also the quality. Because sometimes, again, people will share information and give basic information like, say, so-and-so has got colorectal cancer. That in itself is not rich enough for us to be able to analyze data and make decisions at a national level. So those are the efforts that we're making. And the good thing is, the moment we can integrate our systems in different facilities and different institutions, the richer the information is going to be.
Okay, we have another caller. David Ngeno from Kericho is on the line. David, good morning. A question or comment for Daktari today?
Okay. In fact, I like to ask the doctor if I could visit one of the sub-county hospitals, could I get assistance there? Is there medical facilities that can detect cancer in those sub-county hospitals?
Right.
Okay.
Thanks, David.
Yeah.
I think, very forthright question. And we've talked about it from the CHP level, but this is, again, seeing the realities. We operate from, I'm going to go to the sub-county. That's what's closest to me, as opposed to I'll go see a CHP, or they'll come to me, or I'll go to a dispensary. Which is a level 2, and so on and so forth.
The reality is, in our country, regional disparities exist in terms of how much people can access healthcare. And those disparities are there, and the reality is this. First of all, health is a devolved function.
Right.
And you'll find that different counties put different emphasis and priority in terms of healthcare and how much resources they deploy towards healthcare in their different regions. And you've heard the stories even in social media, or whether it's from other reports, you'll find a particular place. You even have counties where people leave other counties and go for treatment in the neighboring county. That is one. So I don't know which county he was speaking from.
Kericho.
But I want to assume, in general, there should be a facility where you've got health workers who are empowered, and you can be able to detect not all types of cancer, but at the end of the day, you should be able to get some level of treatment, of screening, for example, and diagnosis of cancer, depending on the level of personnel. Now, the key thing is, again, to have a referral system. Because, for example, we've got regional cancer centers, all right? So when you've got this detection at a lower level facility, in terms of, I'm saying lower level in terms of technical capacity, you can go to regional cancer centers. Again, those are not there countrywide. We've got about I think, 17 cancer centers in our country.
Right.
You've got some that offer comprehensive care in the different counties, and then the national ones, and a few in counties, and then some again offer now not necessarily comprehensive, but they provide surgical and systemic treatment.
Let's talk about resource, both human and physical. You often see stories about a chemotherapy machine has broken down in Kenyatta National Hospital. Now patients are being forced to queue twice as long. These are life and death situations. Let me start with just a basic one. How many radiotherapy machines do we have in the country?
I've said we have got about 17 cancer centers, but comprehensive ones are 6, which means the ones that have got radiotherapy machines. Then you've got others in private sector. So we've got Kenyatta National Hospital, Moi Teaching and Referral, and KUTRH, those are the national ones. Then we've got Nakuru, Garissa, and Garissa, which is the other one now I'm forgetting. And Mombasa, all right? Yes.
Okay.
And Mombasa, those are the comprehensive centers. Then you've got others where, again, you've got other cancer centers which provide systemic treatment or surgical treatment. And then in the private sector, one of the things that we need to address, and one of the things I'm passionate about, is we've also got redundant capacity in the private sector, believe it or not, which is not being utilized. So at the time when you've got one machine broken down somewhere and people can't be able to access care, we have got to look for a way in which we have got a platform where we know where there's capacity, so that these patients can be channeled to those areas. And regardless of, and so most of the time you'll find the person who is paying, for example, if it's social health insurance, is the one that is paying. Just divert those patients to those locations as opposed to keeping people waiting. You've got some places where you've got queues and people waiting months before getting treatment. And you've got some private facility somewhere where people are sitting waiting for clients to come. So those are things that in terms of sharing resources that we have to do.
But even the places where there's queues, they can't refer them. That's a gap. If somebody keeps coming back, and isn't it upon the health workers?
But you understand, but sometimes the health worker doesn't know that the next facility down the road has got
a gap.
Yes,
that's another gap.
Yes.
Yeah.
I think it comes back into that issue of fragmentation.
Yes.
Yeah,
In everything.
true.
Fragmentation in research, fragmentation in care, and I don't know whether it's just the entire malaise that we have in this country, the silo mentality, the gatekeeping mentality. I think we gatekeep because you want this to be my forte and I own it, and I don't want anyone else to. If you come in, you're coming to interfere. Maybe it's because of trying to protect the funding that you're getting, so you'll be the only one that is enjoying this funding. I don't know the kind of frustration. I mean, you've been in this sector, in the health space for years, Dr.
Yes.
When I talk about this gatekeeping, I'm sure you know it. From the private sector, you're in the private sector, you're now in the public sector space. What is our problem?
I think I don't even think it is a conscious effort. I think what happens is a lot of the time when you've got systems that grow organically based on need, there's no time to be able to organize a system and say this system should be organized in such a manner. For example, a lot of the private and faith-based facilities came up because there was a shortcoming in terms of the public healthcare system wasn't working. Now, and then again, you find a lot of institutions that grow up in this, that come up, especially in the private sector, are basically family-owned. It's not like you're going to be sitting and saying, let us go and see, is that other facility having this ABC? What you're worrying about is your own capacity and what you can do. So that's what I'm saying in terms of the coordination and communication between facilities. It's actually rudimentary, you're actually not there. And those are the systems that we need to put in place so that you don't have patients queuing and waiting endlessly. And even if it's not the facilities that are communicating, let there be a platform where the patient can be able to log in and find out, I need to get cancer care. Where do I go? And you're told you've got these options. These are the care centers that we have. You've got these options. Have a way of logging in and can I get an appointment? Those kind of things are what we need to be able to say.
What I'm detecting you saying, which you're not saying, but maybe you'll not saying, is that, well, this is the job that the National Cancer Institute of Kenya has, right? To coordinate all these things, to make it easier, moving from fragmentation to integration. But you face some resistance, right? Either resistance because of lack of awareness, or resistance because of suspicion, resistance because of whatever. What are those things? What is the feedback that you get or the pushback that you get when you try to integrate, to bring all of us to say, we are all treating the one patient who is in this country, who needs to be treated by us?
I would not call it resistance. I would say we are facing some challenges.
All right.
How politically correct?
No.
Challenges.
The doctor is like, I fixed the word for you. It's a challenge.
And by the way, I say this because it is a capacity issue. You know, let's be honest, as a National Cancer Institute, we might have the name and say we are National Cancer Institute, but we don't have a lot of capacity.
You're not a national outlook.
We don't have a lot of capacity in terms of resources. And let's be honest, I'm a doctor myself, and I practice in this field for 30 plus years. I'll be honest, before I joined the Cancer Institute, I didn't know too much about it, right? It is something that in the last year or two is now when we're ramping up this. So we are trying to get this going, but it takes a while for us to get the kind of resources we require. We don't have the kind of resources we would like in terms of personnel, in terms of financial resources and so on. So that is work in progress. So we've got a very big vision, all right? And the bottom line is we have got to do what we can with what we have.
For now.
Yes.
I don't want to forget to ask about alternative treatments and how concerned you are about that, because I think more and more I've heard quite a number of people and their families say we'd rather turn to that first. How much of that are you interacting with in terms of alternative treatments? How concerned are you? And then how do you address it without also dismissing like cultural beliefs?
Yes.
Maybe that's what they know, that's what they've known growing up is that you do this. So how do you navigate that alternative treatments for cancer?
Alternative treatments is an interesting area. One, you cannot disregard, all right? Because the truth is there are a lot of those alternative treatments that are beneficial. To what extent? Sometimes not really documented. And a lot of the time people come with anecdotal reports of so-and-so had this cancer and this, and they took this and now they are healed, all right? Sometimes it's very difficult to verify. To be responsible on our part in the absence of there being very clear studies that document and validate these treatments, we can't recommend them to other people, all right? We can't recommend them on a large scale. And all the time, especially a lot of people in that space will say we are, as medical doctors, what we call conventional medicine are being dismissive. But I think by and large, and especially as I've gotten older in the profession, you learn to embrace some of those things and at least give them a hearing, all right? Because
I was going to ask how to do, because I think the dismissiveness sometimes may push people away, as opposed to it's like, okay, daktari doesn't want to listen to me, ananita mimi mtu wa mitishamba, so let me just go with my mitishamba.
And one thing that
as
you must
opposed to working on something.
One thing that also works against us in so-called conventional medicine is that sometimes we don't listen enough. And maybe we also don't promise enough. You know, the alternative medicine people sometimes promise people everything. I'll come and tell you this, we can't treat. We can only manage, you're looking at ABC. And the other person across the street is telling them you will be cured, right? Guess what? They're going to go to that person and try. And if it doesn't work out, the cure doesn't come, they will come back and they come back when it is worse. And that's why I'm saying there's some discussion that needs to be had. And I'll give you an example. When I was a young doctor many years ago, there was this drug called Pearl Omega that was introduced for HIV, all right? And I had a patient at that time and they came and said they want to try this thing. For us, there was nothing we were offering at that time. Antiretrovirals were literally just being talked about, they were not available. And he got 12 bottles of this thing. And he said he wants to take it in the ward. Okay. And I said, you know what, as long as you're not asking me to prescribe it, we'll regard that as your supplement or whatever it is. And the guy took down 12 bottles of this thing, and after a while, and that time it was costing 35,000 shillings per bottle. For the 12 bottle, it was like in a wine bottle, a green wine bottle. And after that, I asked him, so, how are you feeling? How are you feeling? He told me, man, doc, my money, I've blown my money, there's nothing here, all right? But it was within his right to be able to try that treatment because I was not offering anything commensurate, similar to what they were promising. So I understand the desperation sometimes when you're in a difficult place, diagnosis-wise, you've been told, we can't cure this, there's not much we can do other than managing you in terms of... So people are going to try those things, but it has to be done. Where I don't like it is especially for patients where we feel cure is possible. If they get distracted by those things, sometimes you lose them and the prognosis becomes worse. But in circumstances where the outlook is not good, I would understand somebody trying those alternative
trying
therapies.
Everything.
Yes.
You know, Cambry also has actually a department that looks at these other alternative medicines. Just trying to understand that research, because also incorporate them in the research and seeking to understand. Professor Arthur Obel, who came up with the Omega, what was it called? Pearl Omega. He was demonized. He was made to sound like, but he was Professor Arthur Obel. He died just recently. He wasn't a madman, was he?
No, he wasn't.
He was actually a researcher trying just to seek ways in which you can address these things.
He was even my lecturer.
There you go.
I did not know.
He was a very big shot, and he came up with this, and it was a global news that, there's some Kenyan guy who was trying to come up with his claims he has discovered a cure for HIV. He was demonized for that. And therefore, even the research that he was working on was not extended, was not supported, was not taken mainstreamed and saying, how do we improve on it? He was just put aside so that these others can come up. Right? And that's the bad part of this whole conversation. Conventional medicine appearing to dismiss alternative knowledge. Let me not call it medicine, alternative knowledge. But maybe there's a space for that, for alternative knowledge to also be brought in to see how can it be mainstreamed into conventional medicine.
And indigenous solutions become very big on that, because it's so easy to have it invalidated. You know, that's how you are cultured, is that anything that isn't from abroad or whatever, let's not really talk about it. But now you're finding, if even aside from medicine, aside from treatments, people are going back to, but this worked, how do we integrate it?
You see, for example, there are a lot of these adjunctive type therapies, for example, acupuncture and so on.
Yes.
I don't understand it, right? So I wouldn't recommend it necessarily to anyone, but I'm sure it does work, right? There are people who have used it, there have been benefits, especially in very different areas. So it's about picking and choosing what works for particular patients. And I think as medical doctors, we also need to broaden our thinking in terms of at least try and get some information about what other options are available, for our patients.
We have another call on the line. Philip, what's his name?
Wendy. Oh, sorry. Oh, Helen from Tanzania. Okay, good.
Transoia.
Oh, I was so happy.
Gone regional.
I know. Okay, so Basi, Helen from Transoia. Good morning.
Yes, thank you, sir. Good morning to you. This is Helen from Transoia County. He's a laboratory officer, and then I just wanted to ask Dr. about this, sir. How is he prepared from his department to ensure that they empower the laboratories in the counties to ensure that the clinical cytologists and then also the histologists are also involved in terms of cancer diagnosis? In that when you find in the counties, we have many officers who have already trained clinical cytologists, and then from departments, we don't have any prepared tools, equipment for them. And some of them, they have to go to practice privately, because at the county level, we do have nothing to practice. So I don't know how they're actually prepared for that. And we are still sending the pap smears to private hospitals, to Nairobi, and anywhere else. I don't know how we are they prepared for the laboratory part of it. We have cytologists, histologists, just following there.
All right. Thanks, Helen.
Yes. We have no tools. Thank you so much.
That's a very good question, Helen, because one of the things in the National Cancer Control Strategy is actually one of the pillars, because the diagnosis arm, in terms of lab support, pathology, and so on, is extremely important for us to be able to get as part of that care continuum in the treatment journey. Now, we have got capacity issues. If you were to ask me whether we're going to get sufficient personnel to be able to provide some of those services in the entire country, it's not possible. It's the same thing like so we just have to look for ways in which we can be able to deliver the care, because at the end of the day, for example, if you have specimens collected peripherally, can we have them processed centrally but at a facility that has got full capacity? Right. Because again, economies of scale come into operation. Then you've got so if, for example, we had a national cancer reference laboratory that was working the way it should, it would be very easy to be able to collect those specimens and get the result. It's very tragic sometimes. You've got people who go in and get histology or lab specimens, and it takes months before they get these results. That is unacceptable. And those are the things that we have to work on in terms of making sure that people can be able to get their results, accurate results, in time, so that we can be able to intervene. Because sometimes, again, you don't want to be getting a diagnosis and being told you had cancer, but this thing was taken 3 months ago, all right? And again, also the reverse is also true. Even if it's negative, you don't want to be sitting there anxious for months.
For 3 months.
Waiting.
The stress alone is giving you other health problems.
So I do agree. And again, now you see the issue of, I said, health being a devolved function again. The amount of reach that we have into the counties is kind of limited to some extent. And that's why that intersectoral collaboration is important. Counties must work as our partners so that we make sure we achieve our national objective, together with them also doing their part.
Yeah, there's another one I don't want to forget, which is, I don't know if you touched on it, Dr. Ari, how much of the cancer burden is linked to environmental. You know, we've done stories here around pesticides, and so whether it's environmental or occupational, do you feel like there's a growing concern around how that also plays a part in the cancer burden?
Yes, it plays a part. I don't know what the local statistics are because again, when I talk about cancers being preventable 40%, it's a whole mix of various things. However, I do know that especially with these things to do with industrialization, we get exposing ourselves to more chemicals, how our farming methods change and so on. You've got people who are using these chemicals. It might even be chemicals that are, chemicals that are licensed to be used, but if the manner in which they're being used without protective equipment, for example, or you get exposed to levels that are not acceptable, those are the kind of problems that we have in our system. And so I don't know what the exact number is, but I do know for a fact that there's an increase in terms of environmental pollution, even in terms of pollution with industrialization. These chemicals end up in our water. You've got chemicals in the air, it rains, so it's got a lot of...
So you have the pestle risk of political, environmental, social...
Literally.
All of it will also bring us into health.
Yeah.
There's a question here from Philemon. I don't know whether you've been asked. I think cancer screening should be compulsory for all citizens yearly. This thing is stressing families. Now I know you will not. I have pneumocosoma. So how would you advise the government to incentivize citizens to go for regular screening?
Right.
Yeah, making things compulsory will never work, right? First of all, from a constitutional human rights perspective, you can see how somebody will be in court the next morning and get orders. However, I always keep saying people have got to see that perceived benefit. All right? People must see that there's that perceived benefit from going for screening and the early diagnosis. And it takes a while for those benefits to accrue and people to see them. But it has to be that those stories start to accumulate and say, I actually was diagnosed with this cancer, it was caught early, now I'm cancer-free. And so on and so forth. So it acts as an incentive. And from there, they also advise their relatives and friends and so on. But people must see the benefit of that cancer screening early diagnosis.
Right.
Maybe it's over time. Just to continue threading on that. Private health providers, insurance providers, sort of have a way of incentivizing you by compelling you to, before we renew, let's start with a screening, right?
They do.
Now, I don't know what other incentive it would come to. Maybe your contributions reducing because you've gone for a screening or something. But people work on that.
Yes.
Some incentive.
Yes.
Let there be an incentive that tells you you will benefit from this if you take yourself to a health facility and go through screening.
Right.
And then it is recorded that actually Eric went through screening.
Yes.
It's important to think around that.
And that's the benefit I'm talking about because now the benefit they're getting is having a lower premium based on their risk profile.
Yes.
So they're saying this person is lower risk than the other person. But at the moment, you might find all they say is, a certain age, this is your premium, right? And it's the same thing even when it comes to driving. It should be the same thing like in other countries.
I was just about to use that as an example. You go a year without an accident, you haven't claimed anything from your insurance. In other countries, premium gets a little bit, lower.
Yes.
As should be the case, I think, for healthcare as well. We're just about to close the conversation. I just wanted to know what's happening as far as expanding our human resource and technology capacity as well for cancer treatment and diagnosis. How many oncologists do we have? How many do we need? We've talked about radiotherapy machines. How many more do we need? And what's the plan to get us to somewhere where I shouldn't have to cross county boundaries to get treatment?
Yes, that's an area where it's essential. Oncologists, the ones we have, are a drop in the ocean. I keep giving an example. There's a time I visited a hospital in St. Louis in Missouri, who are partners. We partner with them on various other activities. And they had 40 oncologists within one institution. And the American doctor was telling us they are so short-handed, they don't really know what to do. All right?
Okay. How many do we have in Kenya?
Roughly, if you ask me, roughly the same number.
Oh my God.
But in the whole country.
And in that place, that alone, the radiotherapy machines they had, I can't remember, was like 15,
Okay.
All right? So
One hospital.
if you were to ask me, the truth of the matter is we have to be very smart about how we use our resources. We have to leverage on technology to make sure that lower level personnel can still be able to see patients in the periphery, be able to make diagnoses aided by technology that are still accurate, and then channel only those patients who need to get higher level care to the specialists that we have. But in terms of training and so on, we will never be able to catch up. So we just have to be smart about, in this resource-constrained environment, We have to be smart how to.
We have to end it there. Thank
Yes.
you so much. Just a bit of feedback. Cancer screening should be carried through like we had in COVID. We had the COVID-19 vaccines. However, would the government be comfortable about it? Financial constraints would be the cry as usual. That's Lenny De Steve. Maria Nyaga says, good eye-opening conversations and congratulations, Dr. Olweny. I remember when I was young, we were always taught about abstinence and good health practices, even in media and lower primary. Why is it not available to this day and age, especially the silent pandemics?
I think he meant like cancer.
Like
probably.
cancer.
Yeah.
Okay. Fair. But thank you very much for the conversation today. Again, like we said, is World Cancer Day, so there's actually going to be a live event in just a few moments.
Yeah.
We'll be crossing over.
A cancer awareness forum that's taking place in Meru. We'll be crossing over there. Also, the principal secretary for medical services is visiting cancer patients at the Kenyatta National Hospital at noon. Are you aware? You're accompanying him.
I'm heading there na nikichelewa munitetee.
All right. Thank you for staying with Fixing the Nation, one conversation at a time. Mariam Bishar, Janet Bogo, Eric Latif. See you back here tomorrow.